and say how we helped heal their son or their daughter. My memories of Grady are filled with the gracious comments of parents and of patients for the team of healthcare specialists with whom I had the privilege of working. After 25 years of school and training, I started a solo orthopedic practice. Over the years, this practice grew, as Senator Isaacson mentioned, and eventually became one of the largest non-academic group practices of orthopedics in the country, for which I eventually served as chairman of the board. During 20 years as a practicing physician, I learned a good bit about not just treating patients, but about the broader healthcare system and where it intersects with government. A couple vivid memories stand out. One are the number of times where patients were remarkably angry about the individuals figuratively, not literally, but figuratively, standing between themselves and their physician in the clinic room, making it so that what the physician was recommending may or may not be possible, whether it was from insurance or regulators or government or the like. And then there was the day that I remember vividly that I realized that there were more people in the office behind the door where we saw patients in the front clinic area trying to fight with insurance and regulators and government than there were in front of the door actually caring and treating patients. And it became clear to me that our healthcare system was losing focus on its number one priority, and that is the patient. As a result, I felt compelled to broaden my role in public service and help solve the issues harming the delivery of medicine, and so I ran for the Georgia State Senate. I found Georgia's State Senate to oftentimes be a remarkably bipartisan place where collegial relationships were the norm. This is the environment in which I learned to legislate, reaching across the aisle to get work done. In Congress, I've been fortunate to have been part of a collaboration that broke through party lines as well to solve problems. Just this past Congress, as you'll recall, it was a bipartisan effort that succeeded in ridding Medicare of a broken physician payment system, and which has now begun the creation of a system that, if implemented properly, will help ensure that seniors have access to higher quality care. If confirmed, my obligation will be to carry to the Department of Health and Human Services both an appreciation for the bipartisan, team-driven policymaking and what has been a lifetime of commitment to improving the health and well-being of the American people. The commitment extends to what I call the 6 principles of healthcare: affordability, accessibility, quality, responsiveness, innovation, and choices. But Health and Human Services is more than healthcare. There are real heroes at this department doing incredible work to keep our food safe, to develop drugs and treatment options driven by scientists conducting truly remarkable research. There are heroes among the talented, dedicated men and women working to provide critical social services, helping families, and particularly children, have a higher quality of living and the opportunity to rise up and achieve their American dream. The role of the Health and Human Services Department in improving lives means it must carry out its responsibilities with compassion. It also must be efficient and effective and accountable, as well as willing to partner with those in our communities already doing remarkable work. Across the spectrum of issues and services this department handles, there endures a promise that has been made to the American people, and we must strengthen our resolve to keep the promises our society has made to senior citizens and to those most in need of care and support. That means saving and strengthening and securing Medicare for today's beneficiaries and future generations. It means ensuring that our nation's Medicaid population has access to quality care. It means maintaining and expanding America's leading role in medical innovation and in the treatment and eradication of disease. So I share your passion for these issues, having spent my life in service to them. And yet there's no doubt that we don't all share the same point of view when it comes to addressing each and every one of these issues. Our approaches to policies may differ, but there's surely there exists a common commitment to public service and compassion for those that we serve. We all hope to improve the lives of the American people, to help heal individuals and whole communities. So with a healthy dose of humility and an appreciation for the scope of the challenges before us, with your assistance and with God's will, we can make it happen. And I look forward to working with you to do just that. Mr. Chairman, I thank you for the opportunity to be with you today.
Well, thank you, Dr. Price. I can't think of anybody who could give a better analysis of why this position is so important to them. Let me start with this question. The Department of Health and Human Services is one of the largest departments in government in employing, I think, nearly 80,000 employees and encompassing over 100 programs covering a large range of complex and diverse issues. Now, you've described to a degree, but if you could elaborate a little bit more, can you describe how you will prioritize and oversee the large array of issues for which you will be responsible? And tell us what in your history has prepared you to lead the Department of Health and Human Services, such a multifaceted department.
Thank you, Mr. Chairman. As you and the members know, the mission of the Department of Health and Human Services is to improve the health and the safety and the well-being of the American people. And in order to do that, I'm committed to that mission, but in order to do that, you've got to put together teams of individuals in each sector of health and human services. In my history, wherever I was, whether it was in my clinical practice or the state legislature or Congress or the work that I did in communities, was just to bring forward the greatest quality of talent that we could assemble. Second is to understand the scope and the issues, and clearly having the experience both in the clinical arena as well as in the legislative arena, understand the scope and the issues. And then finally, focusing on results. I think oftentimes it gets kind of muddy up here in Washington what we do. We name the programs, we make certain that the resources are there to be able to provide money for the programs to be run, but oftentimes I think we drop the ball on whether or not we're actually accomplishing the mission. Are we truly improving the health and the safety and the well-being of the American people? So one of the major goals that I have is to look at the metrics that we're looking at the department and making certain that we're accomplishing that mission and that goal.
Well, thank you. The Centers for Medicare and Medicaid Innovation, CMMI, has begun numerous initiatives over the past few years, some of which have generated much controversy. Could you tell us your position on the work in CMMI and how it should or should not be continued in the future?
Yeah, thank you, Mr. Chairman. The innovation is so incredibly important to health care and the vibrant quality of health care that we need to be able to provide to our citizens. Innovation, in fact, is what leads quality health care. It's what expands the ability of health care professionals to be able to treat patients. So I'm a strong supporter of innovation, and I think one of the roles that we as policymakers have is to incentivize innovation. The Center for Medicare and Medicaid Innovation is a vehicle that might do just that. I think, however, that CMMI has gotten off track a bit. I think that what it has done is defined areas where it is mandatorily dictating to physicians and other providers in this country in certain areas how they must practice. So whether it's a geographic area that includes 67 or 68 areas in our country that have to perform a certain procedure in a certain way and use a certain implant in a certain way because the government says they've got to mandatorily without exception, or whether it's 75% of the Part B Medicare drug demo, it's called a demonstration project, which dictates to physicians and other providers what drugs they must use in an inpatient setting. That, to me, is no longer a trial. That's no longer an experiment. That's no longer a pilot project to determine whether or not an innovative solution might work. That's changing the way that American medicine is practiced by folks making decisions here in Washington, as opposed to patients and families and doctors making those decisions. So, strong supporter of innovation, hope that we can move CMMI in a direction that actually makes sense for patients.
Well, thank you so much. Medicare has lost more than $130 billion, that's with a B, to improper payments over the past 3 years. The program has also been above the legal billing error rate threshold of 10% for the past 4 years. Given that Medicare trustees have issued grave concerns about looming Medicare insolvency if we stay at the current spending levels, will your administration actively champion our Medicare integrity program so that we can recover a much higher percentage of the billions of taxpayer dollars lost each year to billing mistakes, and ensure that Medicare will be in place for future American seniors? And also, as a former practicing physician who has experience with Medicare and Medicaid programs, do you have any insights into steps you think should be taken to address the multi-billion-dollar problem of waste, fraud, and abuse in these programs?
Yeah, thanks, Mr. Chairman. That nobody supports care being billed for that isn't needed or hasn't been provided. And this is one of those areas that I think we need to be very, very focused. I'm certain that there are some bad actors out there. I think they're a minority, but there are some bad actors out there. And I'm certain that if we were to focus specifically on those bad actors in real time, which is what happens in every other industry in our country, that real-time information is available and acted upon. Instead of trying to determine whether every single incident of care is necessary, if we were to focus on those individuals that were the bad actors specifically, then I think we could do a much better job of not just identifying the fraud that exists out there, but ending that fraud.
Well, thank you. Senator Wyden, we'll turn to you now.
Thank you, Mr. Chairman. Congressman, I'm going to start with the trading in health care stocks. Your position is that the trading was legal because, in your view, it complied with House rules. I think there are debatable legal questions, but there are other matters. Innate Immunotherapeutics is an obscure Australian company that develops a treatment for immune system disorders and plans to seek FDA approval. Innate's fortunes are affected by congressional action. Today, the total value of your shares exceeds $500,000. Yet on the Office of Government Ethics disclosure form you filed as a nominee, you significantly undervalued the stock. You failed to include the value of more than 400,000 shares you bought at a significant discount during a private stock sale made available to specially chosen investors around Labor Day. You also significantly underreported the value of this purchase to the committee. It's worth more than twice what you reported. You heard about the stock from a House colleague who is a board director of this Australian drug company and the largest shareholder. You got in on private placements not available to the public. In these private placements, you bought over 400,000 shares at discounts that were as much as 40% cheaper than the price on the Australian Stock Exchange. And you were sitting at the time on committees that have jurisdiction over major healthcare programs and trade policy. Yes or no? Doesn't this show bad judgment?
Well, if what you said was true, it might.
We have a paper
but
trail.
The fact of the matter is that's not the case.
We have a paper trail for every comment I've made. Yes or no? Doesn't this show bad judgment?
No.
Well,
let him answer the question too. I mean, you kind of indicated you did something wrong. Let him explain why it wasn't wrong.
It was a yes or no.
No, I want to have him be able to handle that problem.
Maybe it would be helpful if you laid out the accusation, sir.
Well, you purchased stock in an Australian company through private offerings at discounts not available to the public.
They were, if I may, they were available to every single individual that was an investor at the time.
Well, that is not what we learned from company filings. Company filings with the Australia Stock Exchange state that this specific private placement would be made at below market rates. The Treasury Department says it's only offered to sophisticated investors in a non-public manner. We have a paper trail for every one of the statements that I have gone into. And trading in stocks while you sit on two committees, introducing legislation that directly impacts the value of the stocks.
What legislation would that be, Mr. Senator?
We will take you through the various bills, but the reality is this has been cited on a number of occasions.
The reality is that everything that I did was ethical, above board, legal, and transparent. The reason that you know about these things is because we have made that information available in real time as required by the House Ethics Committee. So there isn't anything that you have divulged here that hasn't been public knowledge.
Your stake in Innate is more than 5 times larger than the figure you reported to ethics officials when you became a nominee.
And if you had listened to your committee staff, I believe you would know that our belief is that that was a clerical error at the time that the 278E was filed. We don't know where it happened, whether it was on our end, whether it was on the end of the individuals of OGE. But there was not any malicious intent at all.
Congressman, you also reported it in the questionnaire to the committee, and you had to revise it yesterday because it was wrong.
And the reason for that is because when asked about the value, I thought it meant the value at the time that I purchased the stock, not the value at some nebulous time when we supposedly made a specific
I want to get in one other question, if I might. This weekend, the President issued an executive order instructing the Department and other agencies to do everything possible to roll back the Affordable Care Act. If confirmed, you'll be the captain of the health team and in charge of implementing the order. Yes or no, under the executive order, will you commit that no one will be worse off?
What I commit to, Senator, is working with you and every single member of Congress to make certain that we have the highest quality health care and that every single American has access to affordable coverage.
That is not what I asked. I asked, will you commit that no one will be worse off under the executive order? You ducked the question. Will you guarantee that no one will lose coverage under the executive order?
I guarantee you that the individuals that lost coverage under the Affordable Care Act, we will commit to making certain that they don't lose coverage under whatever replacement plan comes forward. That's the commitment that I provide to you.
The question, again, is will anyone lose coverage? And you answered to something I didn't ask. I'll wrap up this round by saying, will you commit to not implementing the order until the replacement plan is in place?
As I mentioned, Senator, what I commit to the American people is to keep patients at the center of health care. And what that means to me is making certain that every single American has access to affordable health coverage that will provide the highest quality health care that the world can provide.
I'm going to close by way of saying that what the congressman is saying is that the order could go into effect before there's a replacement plan. And independent experts say that this is going to destroy the market on which millions of working families buy health coverage. And on the questions that I asked, will the congressman commit that nobody will be worse off, nobody will lose coverage? We didn't get an answer. Thank you, Mr. Chairman.
Well, how can anybody commit to that? Let me just say, Dr. Price, you've been accused here of investing in securities that had a direct effect over in Congress, and you disclosed the wrong value of shares you owned in Innate Immunotherapeutics. Now, Dr. Price, let me just say this has a diversified portfolio with Morgan Stanley in a broker-directed account. Correct me if I'm wrong on any of this, Doctor. The portfolio includes both healthcare and non-healthcare stocks. His financial advisor designed the portfolio and directed all trades in the account. The advisors, and not Dr. Price, has the discretion to decide which securities to buy and sell. On March 17, 2016, in a periodic rebalancing of the portfolio, the financial advisor directed the purchase of 26 shares in Zimmer Biomet, worth under $3,000. The advisor notified Dr. Price of the purchase on April 4, 2016, and Dr. Price disclosed them on his House periodic transaction report on April 15th. Now, Dr. Price began his legislative effort related to the Comprehensive Joint Replacement Demonstration Project in 2015. With one exception, all of Dr. Price's stocks are held in 3 broker-directed accounts. Neither he nor his wife direct or provide input regarding investments in these accounts. Innate Immunotherapeutics is the one exception. Now, Dr. Price decided to invest in, I'll just call it IL, based on public information regarding his work on multiple sclerosis treatments as a disease. He has been intimately involved in treating for years. He directed the investments based on his own research into the company. He invested $10,000 in the company in January 2015 and reported the investments to Health Ethics in February of that year. He made an additional investment in September 2016 and also disclosed that investment. He has corrected his filing regarding the value of his shares. He's agreed to divest all shares in the company. I don't know. Is that a correct set of
Your
remarks?
summation is correct, sir. And I just point out that anybody who knows me well knows that I would never violate their trust. And I know the environment that we're in here. You mentioned it in your opening statement, but I appreciate you correcting the record.
Well, thank you. Let's see.
Mr. Chairman, just an inquiry. You just consumed about 2 minutes beyond your opening statement. And in the interest of fair play, is it appropriate for someone to note that 2 minutes is also owed to Senator White or somebody on our side?
Well, you already did go over 2 minutes, so
Okay.
that's no problem.
But as we go forward in this process, I would just ask you to keep that.
Well, I'm not going to relinquish my role as chairman.
No, I understand.
To correct errors that are promulgated here, and but I've
just-
always been good about giving time that you need. So I will try to do that.
Good, thank you.
But I'm also not going to allow things that are not false, things that are false, to go forward without some sort of comment.
All right.
We just can't allow this to happen.
Mr. Chairman, just a unanimous consent request.
Yes.
Bipartisan disclosure memo, I'd like to ask be made a part of the record because it will document what I've stated.
Without objection. Senator Roberts.
Did you really wink at me and smile? Bless your heart. Thank you. Good doctor. Thank you for coming. I think it's important to make clear right off the bat
talking about in this CBO report, lower than current law, and beneficiary cost will decrease by 6% on the average, which is what you said yesterday. But in high-cost regions like Florida, you're going to have the higher beneficiary cost than current law under your premium support proposal. Annual premiums in Florida would increase 125% according to the CBO chart on page 71. CBO says that the annual premium in a high-cost region like Florida would be $3,600 compared to the current law of $1,600. That's the 125% increase. So please help clarify what you were saying yesterday as it applies to Florida.
Yeah, thank you, Senator, and I enjoyed our time together as well. When we talk about Medicare, it's important for everybody to appreciate, as I know that you and your colleagues do, that the Medicare trustees, not Republicans or Democrats, the Medicare trustees have told all of us that Medicare in a very short period of time, less than 10 years, is going to be out of the kind of resources that will allow us as a society to keep the promise to beneficiaries in the Medicare program. What that means, it's important to appreciate what that means. It means that we will not be able to provide the services to Medicare patients at that time, which is very, very close, if nothing is done. So my goal is to work with each and every one of you to make certain that we save and strengthen and secure Medicare. I think it's irresponsible of us as policymakers to allow a program to continue knowing that in a few short years it's not going to be able to cover the services that were provided. So that's the first point, and that is the current Medicare program, if nothing is done, as some have described it, goes broke. Second point is that my role, if I'm able to be, if I'm confirmed and have the privilege of serving as the Secretary of Health and Human Services, my role will be one of carrying out the law that you all in Congress pass. It's not the role of a legislator, which I had when I was working to try to formulate ideas to hopefully generate discussion and get to a solution.
Let me be so rude as to stop because I'm running out of time. Remember that Donald Trump in the campaign said that he was not going to cut Medicare spending. And I would also point to you, in a legislative solution, one of the greatest examples on Medicare is 1983, when we were just about to go bust, and it took two old Irishmen, Reagan and O'Neill, to agree to come to an agreement that made Medicare, well, in this case it was not Medicare, it was Social Security, actuarially sound for the next half century. Let me ask you, Representative Price, you had made a statement that it was a terrible idea of people who had pre-existing conditions that they would have the protection of insurance against those pre-existing conditions. And what I'd like to ask you is, can you please, in light of President Trump expressing his desire to retain this basic protection, do you think his proposal to continue the ban on discriminating against people with pre-existing conditions is a terrible idea?
No, I'm not certain where you're getting that quote from. What I have always...
From Politico, Talking Points memo, May the 1st, 2012.
Oh, well, now there's a reliable source. What I've always said, Senator, is that nobody...
So you didn't say it's a terrible idea?
I don't believe I ever made that statement. What I've always said about pre-existing conditions is that nobody, in a system that pays attention to patients, nobody ought to be priced out of the market for having a bad diagnosis. Nobody. That's a system, again, that may work for insurance companies, may work for government, but it doesn't work for patients. So I believe firmly that what we need is a system that recognizes that pre-existing conditions do indeed exist, and that we need to accommodate it and make certain that nobody loses their insurance or is unable to gain insurance because of a pre-existing condition.
Mr. Chairman, as I close, I would like to insert in the record the September 2013 Congressional Budget Office analysis of premium support system for Medicare. And I would invite you, Congressman, to please respond with the CBO report that you said yesterday that supports your position, because this one does not.
Look forward to that. Thank you, sir.
Well, thank you, Mr.
Senator Menendez.
Thank you, Mr. Chairman. Congratulations, Congressman Price. Let me ask you a series of questions. Given your medical training and time spent as a practicing physician, I have a couple of simple yes or no questions to start off with. In your medical opinion, does HIV cause AIDS?
I think that the scientific evidence is clear that HIV and AIDS are clinically directed.
In your medical opinion, have immigrants led to outbreaks of leprosy in the United States?
I don't know what you're referring to, but I suspect that there are instances where individuals have an infectious disease and they come to the United States, and that
I'm not asking about an infectious disease. I'm asking specifically about immigrants in the United States causing leprosy in the United States, in your medical opinion and scientific background.
Again, I don't know what the incident to which you refer. Are you referring to a specific incident?
There are statements that have been made in the public domain that immigrants have led to outbreaks of leprosy in the United States. As the person who's going to be designated as the Director of Health and Human Services, that is not only the national but the world's health epicenter, I want to know, in your medical opinion, is there such a causation?
Anytime you get two individuals together in any relationship whatsoever, whether it's an immigrant or a visitor, and one individual has an infectious disease, then it is possible that that individual transmits that infectious disease.
Including leprosy.
Whether it's the flu
including
or
leprosy.
cold,
Including leprosy.
In any infectious disease whatsoever.
In your medical opinions, do abortions cause breast cancer?
I think the science is relatively clear that that's not the case.
Mm-hmm. In your medical opinion, do vaccines cause autism?
Again, I think the science in that instance is that it does not, but there are individuals across our country.
I'm not asking about individuals, I'm talking about science, because you're going to head a department in which science, not alternate universes of people's views, is going to be central to $1 trillion budget and the health of the nation. Can you commit to this committee and the American people today that should you be confirmed, you will swiftly and unequivocally debunk false claims to protect the public health?
What I'll commit to doing is doing the due diligence that the department is known for and must do to make certain that the factual information is conveyed to
and that
Congress
factual
and to the
information will
President
be dictated by science, I would hope.
Without a doubt.
Okay. So let me ask you about Medicaid specifically. And let me just say I'm a little taken back about your answer on the question of immigrants and leprosy. I think the science is pretty well dictated in that regard, too. Let me ask you this. One of the most beneficial components of the Affordable Care Act was the expansion of the Medicaid program that resulted in 11 million people nationwide and over 500,000 in New Jersey gaining coverage, many for the first time. It's one of the biggest programs on the Republican chopping block, with proposals to not only repeal the Affordable Care's Medicaid expansion, but going further and gutting billions in federal funding to the states. There's no doubt that this would result in catastrophic loss of coverage for tens of millions of low-income families and lead to tens of billions in losses to safety net and other health care providers. Do you recognize Medicaid to be a valuable program and consider the coverage it provides to 74 million Americans to be comprehensive?
Medicaid is a vital program for health care for many individuals in this country, but one that has significant challenges There's 1 out of every 3 physicians who should be seeing Medicaid patients who are not taking any Medicaid patients. There's a reason for that. If we're honest with ourselves, we would be asking the question, why?
Well, if that's the case, that 1 in 3 don't treat Medicaid, you have to ask yourself, is that because Medicaid reimbursements are so low? And since provider reimbursements are set at a state level, won't cutting federal funding and hitting states with higher costs only lead to lower provider rates? And how many doctors would actually treat former Medicaid beneficiaries when they no longer have any coverage or ability to pay? So even if there's only 1 of 3, there's still 2 of 3 that are providing the services. Imagine if you don't have coverage, which goes to my next question. You have advocated to, in essence, block grant Medicaid. Now, the essence of Medicaid is an entitlement, which under the law means if I meet these criteria, I have the right to have that coverage under the law. When you move to a block grant, you remove the right and you make it a possibility, subject to whatever funding there's going to be. Do you recognize that in doing so, you risk the potential of millions of Americans who presently enjoy health care coverage through Medicaid no longer having that right?
I think that it's important to appreciate that no system that the President has supported or that I have supported would leave anybody without the opportunity to gain coverage. Nobody.
Well, that's not my question, so let me reiterate my question. Medicaid, under the law as it exists today, is a right. Is that not the case, yes or no?
It's an entitlement program.
And as an entitlement, doesn't that mean you have the right if you meet the criteria that you are entitled to the services of that program?
One is eligible, that's correct.
One is eligible, meaning you have a right. When you move to a block grant, do you still have the right? No.
I think it would be determined by how that was set up, if in fact that was what Congress did. Again, the role of the Department of Health and Human Services is to administer the laws that you pass.
Yeah, but I would just simply say to you, I know in our private conversation, I appreciate you coming by to visit me, you suggested that your role is that of an administrator of a large department. Well, that's not even what the Vice President said when you were nominated. He said he expected your experience both medically and legislatively to help drive policy, and even beyond the expectations of the Vice President in that regard, when we have regulatory abilities of the Secretary to dictate regulation, that is policy. So please don't say to me that I am here just to do what Congress says. I respect that you will follow the law and do whatever Congress says, but you will have an enormous impact. And based upon your previous opinions, as it relates to Medicaid, ultimately, block granting means a loss of a right. And then it's just a question of funding, and then we'll have a bigger problem with the number of providers willing provided. So I hope we can get to a better understanding of your commitment to Medicaid as it is as an entitlement, as a right.
Thank you, sir.
Senator, your time is up. We'll go to Senator Carper now.
Congressman Price, welcome to you and to your wife. There's a verse of Scripture you mentioned earlier that you're active in your church. There's a verse of Scripture in the New Testament in Matthew 25, which speaks to the least of these. When I was hungry, did you feed me? When I was naked, did you clothe me? When I was thirsty, did you give me to drink? When I was sick and in prison, did you visit me? When I was a stranger in your land, did you take me in? It says nothing about when my only access to health care coverage was going into the emergency room of a hospital. Did you do anything about it? What we sought to do with the ACA is to do something about it. And we didn't, in this room, invent the Affordable Care Act. The genesis of the Affordable Care Act goes back to 1993 when Hillary Clinton, First Lady, was working on what was called Hillary Care. And a group of senators led by Senator John Chafee, a Republican from Rhode Island, developed legislation co-sponsored by, I think, 23 senators, including, as I recall, Senator Orrin Hatch and Senator Grassley. And what he did in his legislation, what he proposed in his legislation, was to use really 5 major concepts. One, to create large purchasing pools for folks who otherwise may not have access to health care coverage. They call them exchanges or marketplaces. He also proposed that there be a sliding scale tax credit to buy down the cost of people getting coverage in those exchanges within the different states. Third thing he proposed was the notion that there should be an individual mandate. They wanted to make sure people got covered, and they realized if they didn't mandate coverage, if people getting coverage, then you would end up with insurance pools that health insurance companies could not began to cover. It just would not be unworkable. It would be unworkable. He proposed as well employer mandates, and he proposed as well the notion that people shouldn't lose their coverage because of pre-existing conditions. Those are not Democrat ideas. Those were proposed by Republican leadership, actually, in the Congress at the time. And when Governor Romney developed his own plan in Massachusetts, I don't know, a decade or so later, he borrowed liberally from those ideas. When they instituted it, as you may recall, they instituted what others call Romney Care. They found they were doing a pretty good job on covering people, but not such a good job on affordability. And what took place over time is you found out they had insurance pools where a lot of the people were not young, they were not very healthy, and they were older, and they needed more health care. And as a result, the insurance companies, in order to be able to stay in business, had to raise the premiums. I don't know if any of this sounds familiar to you, but it sure sounds familiar to what we've seen in the last 6 years or so with the Affordable Care Act. To the ideas of Senator Chafee and the ideas of Governor Romney, we have added some things. We have we've encouraged states to increase the number of people they cover under Medicaid by raising to about 135% the poverty level under which people can receive health care. We've encouraged to focus on prevention and wellness, not just treating people when they're sick, but also trying to make sure that people stay healthy in the first place. We provide funding for contraception. We provide funding for programs that are inclined or intended to reduce obesity. We have programs that are intended to reduce smoking, the use of tobacco. This is not a yes or no question. What was wrong with that approach? What is wrong with that approach? And the last thing I'll say is this before you answer. The health insurance companies found it difficult to stay in business in the state group exchanges across the country. One of the reasons why they were unable to is because, I think, we learned this from Massachusetts, we didn't raise the fine, or if you will, we didn't have the incentive high enough to get young, healthy people like my sons into the exchanges across the country. S&P, I'm told, has just put out about a month ago an update looking at the financial health of the health insurance companies in this country as they have tried to figure out how to price this product. And it seems like,